Welcome to our show, Forum 360 with a global outlook and a local view. I'm Ardith Keck, host. What do you do in case you think you're having a heart attack? How to best take care of your heart? And newest treatments for the care of a patient with a heart in mind. These are all topics we'll talk about with Dr. David Cutler, cardiologist. Dr. Cutler has been specializing in the treatment of hearts of patients for 24 years, so he knows what he's talking about, and is a respected member of the medical community. Welcome, Dr. Cutler.
Thank you so much for having me today, Ardith. It's great to be here.
Great. How prevalent is heart disease?
It remains the #1 killer of people in the United States, cardiovascular disease. It affects tens of millions of persons in the United States. The prevalence is actually going up some because of the risk factors. So unfortunately, I have job security for another 20 to 30 to 50 years because of the number of people who are suffering with heart disease.
You say the rate is going up. Why is that?
Unfortunately, despite a lot of efforts to improve some of the risk factors, for example, smoking is actually down compared to when I was in training 25 years ago. About 16 to 18% of people smoke still, but that's better than it used to be. But things like diabetes and obesity are up, and those are tremendous risk factors for heart disease, and together that's increasing the overall prevalence in the United States.
Is it true of both men and women?
It is, unfortunately, and in fact, although women tend to get heart disease later than men, which is true by about 10 years, when they get it, they actually don't even do as well. So it is, unfortunately, a problem with diabetes. And the diabetes, a lot of it is because of the prevalence of obesity, which is a risk factor for diabetes. And the diabetes then causes problems with the circulatory system, as well as other problems in other organ systems, such as the eyes and the kidneys and the neurologic system. So that combination has really increased the overall numbers of people with heart disease in the last 10 to 20 years.
How do women know if they have heart disease?
Well, as I think most people know, women can have less typical symptoms than men. Back again, when I was in training, there used to be thought that, well, women didn't really get heart disease, don't worry about it. And that's clearly not the case. And I think most good physicians, cardiologists, and primary physicians realize that heart disease is just as important in women and men. I know women worry very much about different kinds of cancer, breast cancer, but in fact, heart disease remains still the #1 killer in women. So women have to be a little bit more attuned to their symptoms, whereas someone having a typical heart attack might say, well, I'm having an elephant on my chest or a chest pressure. There's a little higher likelihood in women of having somewhat less common features. You might have an elephant sitting on your chest. It may be an aching. It may be a shoulder aching. It may be shortness of breath. So you have to have a higher index of suspicion that whatever symptoms you're having could be from your heart. I think things that occur if you're having it for a period of time and it's occurring with activity, with exertion, you need to be a little bit more concerned about that. Shortness of breath, chest pain, arm pain with activity. Even if you don't think it's a heart thing, it's probably worth mentioning to your doctor.
How do men know they have heart disease?
Well, men also can have typical symptoms like chest pressure, but unfortunately in both men and women, about a quarter of people find out the hard way. Their first inkling that they have a heart problem is a major cardiac event, either sudden death or a heart attack. And that's really one of the hard things about cardiology is even though we have risk factors and risk factor models looking at your family history and high blood pressure and diabetes and cholesterol and smoking, there are still about a quarter of people that just show up with their first event being an unexpected heart attack or death. And that's really a tricky thing, is to try to get those people diagnosed before they have a bad event. And there are certainly some ways that are being done now which weren't available 10 or 20 years ago.
Yeah, if someone has heart disease, what can they do about it?
Well, if you have heart disease and you find out about it, people actually do pretty well unless they're unstable or unless they've had a major heart attack. People who have coronary disease, even if they've had a stent or something done to the blockages, if they're doing well, they tend to do pretty well. There's certainly an ongoing risk of events, but by avoiding cigarettes, weight loss, trying to exercise, treating your diabetes, treating your blood pressure, treating your cholesterol aggressively, making sure you take your medicines, especially aspirin and any other blood thinners if you're on them for stents, really decreases your risk of events, and people do really well. People with chronic heart disease do well, especially when they're stable. What we want to avoid is taking a stable patient and have them become unstable. So I think there's a lot of great medicines out there that weren't there 20 or 25 years ago to keep people doing well once they have a diagnosis.
And you mentioned diagnosing heart disease, that there are new treatments and new ways to determine that.
I think one of the hard things is if someone is not having symptoms and you don't want them, and they don't want to be that 25% that their first event is a major heart event, is there anything out there? And most people, I think, know about stress testing. You walk on a treadmill and we look at the electrocardiogram and see if there's any changes. And I think most people are also aware that it's just not a great test. It's pretty good to pick up heart disease, but not great. And there's a lot of false positives, meaning someone will walk on a treadmill, we think it's abnormal, and lo and behold, down the road, they really don't have any major blockages. The other thing is, we know, is people who are pretty active, who don't have symptoms, don't tend to get much out of a stress test as improving your diagnosis. So stress tests won't pick up somebody until they have significant blockages. And what we're looking to do is to try to find people who have early blockages, early buildup of cholesterol in the heart before it causes a problem and before it causes a heart attack. And there's a couple of new techniques out there, specifically one called calcium scoring, which you can do, which is a very easy, relatively inexpensive screening test. And it's about a 5-second CAT scan that are done in men and women. And generally, we reserve this for people 45 to 50 or older who do not have symptoms, but who have significant risk factors. The American Heart Association recommends people that would be considered at what intermediate overall risk, meaning a 10% risk of a major cardiac event within 10 years.
They may be obese or
overweight, family history, high blood pressure, smokers, and they're worried, do I have to be worried about my heart? And this calcium scoring test is a relatively easy way to sort of reclassify them. And what it is, it's a 5-second x-ray of your heart with a CAT scan, very low radiation, no IV, no IV dye. You show up, you have it done. And if there is cholesterol buildup in the heart, generally you'll see bits of calcium in the heart. Calcium goes where cholesterol goes. It's not the kind of calcium you eat or have to do with calcium in your bones. It's called dystrophic calcium. It goes where coronary artery disease is. So if you do a scan and there's no calcium or very little calcium, you're at very low risk for an event for 5 years, and it's very reassuring. Conversely, if you've got a lot of calcium, that means you've got a lot of plaque in there. It doesn't mean you're about to have a heart attack tomorrow, but your risk is significantly higher if your calcium score is on the high side. What do you do with that information? Well, the important thing is, number one, it can affect lifestyle. If someone does smoke, we can use that as sort of a little bit further evidence to say, you know, maybe this is another good reason. You've got coronary disease, even though it's not necessarily severe, you've got to stop smoking. The thing is, we think as docs, is that you probably need aggressive treatment for your cholesterol with the statin drugs that are out there if you've got a fair amount of coronary calcium. These drugs not only prevent progression of cholesterol in the arteries, they seem to prevent heart attacks, meaning whatever you've got, it may not go away completely, it's not going to, but the statins seem to keep things quiet so people don't go on and have acute events like heart attacks or unstable angina, things like that. So we tend to use a calcium score test to guide cholesterol treatment with the statin drugs. Again, calcium score isn't for everybody. If you're 30 to 35, you're probably too young to get it. If you're having chest pain, it's probably not appropriate. But as a screening test in people who have concerns, and I find this in my patients who come in to see me, it's the people with family history. Their dad either had a heart attack or died at age 45, 50, 55, somewhere on the young side. And they are really scared to death that they're going to have the same fate. And they want to know, do I need to worry about this? And sometimes a calcium score can be very helpful, because if you have a calcium score and it's 0 or very low, they get a lot of reassurance. And if it's high, it allows us to act sort of with a more aggressive manner medically to make sure that they don't have the same fate.
Can most people tolerate statins?
Yes. I know that there is a concern out there about statin drugs. And when you read the package inserts, there's a risk of myositis, which is actually inflammation of the muscles. That is very, very rare. There is a risk of myalgia, which is muscle pain and soreness, and that is pretty common, probably in the range of about 10%. There are occasionally abnormalities of liver enzymes which occur, but people do not die of liver failure because of the statins. There's also some very questionable data about whether statins can increase diabetes prevalence. That is debatable, but it is a legitimate concern. There's also been stuff out there that people will read about memory impairment with statins. And as a cardiologist, I personally have seen that literature. I think it's very underwhelming that it's actually accurate. The diabetes literature is questionable. So I would say to you that even people with the muscle aches on the statins, most people can tolerate it by adjusting dosing, adjusting frequency, trying a different statin. Even sometimes we use some of the statins in an off-label use, maybe once a week at a high-potency statin, which will still allow a fair amount of benefit. Go ahead, I'm sorry.
Go ahead.
Well, we don't use statins in just everybody. You have to have either significant coronary disease, significant vascular disease in your neck and your legs, have had a heart attack, have a significant amount of calcium on a calcium score, or have a very, very high bad LDL cholesterol. So it isn't like we've put statins on into everybody. It's just for people with what we think are higher risk situations.
As a person who takes statins, I'm happy to hear that it doesn't affect your memory as much.
No, I know people have legitimate concerns, and as a cardiologist, where we know that the data for statins is really, really good. I mean, there is strong data on stroke prevention, heart attack prevention, mortality reduction. Those are really great things. And so when folks are worried about taking these meds, about my memory, I try to reassure them that that is really a very low risk, and most of the data out there really does not support that has any major effect.
Okay. We're talking today with Dr. Cutler, Dr. David Cutler, who is a cardiologist, and he's been a cardiologist for 24 years, and we're happy to have him with us today. I'm Ardith Keck, your host. And you talked about some of the symptoms of a heart attack in women, but I think that's worthy of repeating. So symptoms of a heart attack with women, it's different. It
doesn't have to be, but it can be. Most people know that you have an elephant sitting on your chest, a chest pressure is sort of a typical symptom when you think of a heart attack. And that is still often the case. But in women, there's definitely a higher prevalence of what we would call atypical symptoms. Arm aching, muscle aching, shortness of breath. Some people get nausea. Sometimes it can be more pain with deep inspiration. So things that we wouldn't necessarily typically think are a heart attack still can be. And I also might add, men can also have these same issues, and also elderly patients much more likely to have what we would consider atypical symptoms. So as I mentioned, the key issue is an index of suspicion. If you are having symptoms, especially if you really feel ill and if the symptoms are getting worse and worse over a period of 15 to 20 minutes, and even if it's not an elephant on your chest, if it's an aching, an arm aching, if it's a jaw pain, there are other things. In those cases, sometimes the smart thing to do is call 911, get to a hospital, and assess your situation. If you're having symptoms as an outpatient and it's with activity, that certainly raises our concern. So even if it's a weird symptom of shoulder pain or back pain or jaw pain or shortness of breath with activity, but it's not what you think is a heart thing, it still is worth mentioning to your doctor and may be worth a further evaluation.
But if you feel that it's important to get treatment, or the suggestion is to call 911?
Absolutely. If you're at home, man or woman, and you're having chest discomfort, jaw pain, arm pain, especially with other symptoms, if you're sick to your stomach, if you're sweaty, if you're short of breath, if you're dizzy, you might be having a heart attack. It doesn't have to be. We have plenty of people that come to the hospital that don't have heart attacks. That's fine. But you have to call 911 early, because if you are having a heart attack, the earlier we can treat you, the better you will do. That has clearly been shown. There's a saying in cardiology, time is muscle. So whenever there's a doubt, we always recommend people call 911, get to the hospital, and then at that point, we can sort it out whether it's a heart attack or something else.
And doctors don't look at people who go to the ER or call 911 because they think they're having a heart attack as someone who I don't know, faking it?
Oh, very rarely. I mean, I will tell you, we have concerns, as you probably are aware. Some of the insurance companies have actually sort of come up with guidelines prompting their patients to avoid emergency room visits, threatening to not pay for an ER visit if it isn't warranted. The problem is that's all retrospective. Once you get there and you get the results, well, that's fine. If you call my office with chest pain at 3 in the morning, most of the time we're going to send you to the emergency room because we do not want to miss someone having a heart attack. Now, there are plenty of patients that I've taken care of over 20-something years who continue to come to the emergency room with chest pain, and it certainly turns out to be non-heart-related pain, and we have people who do fake things. But for the vast majority of people who go to the emergency room, it's for a legitimate concern. Most people going to the emergency room with chest pain do not have a heart attack. Many of them don't even have heart-related chest pain. But that is, again, that's the whole point of going. But if it's something where it's ongoing and it's not better within 15 or 20 minutes, you know, I think the better part of valor is to make that phone call, get to the hospital, make sure you're not having a heart attack.
Is there a dramatic change in treatment of heart attacks?
Well, there has been within the last 20, 25 years. When I was in training, very, very rarely did people go right for an emergency heart cath to look at the arteries and put something in. The stents have been around for about 25 years, 30 years, but it's really the last 20 years that have been this what's called primary PCI. That means get someone to the heart cath lab, look at their arteries, and open it up with a balloon and a stent and get that artery open. It's called prompt revascularization. Revascularization means opening the artery. That has markedly reduced the mortality in people having heart attacks. When I say to you that people do better with heart disease, they do. It's just there's more people having heart disease. But because of this aggressive treatment of people having heart attacks, getting to the cath lab, trying to open the artery up, people have done much, much better, much less damage, much less chronic heart failure because the muscle is being salvaged.
So that's the reason speed is important.
Speed is very important. Also, there's been an advent of newer blood thinners in the last 25 years where now you can safely put stents in arteries where there's blood clots and blockages and cholesterol buildup without the stents closing up. And because of these newer and better blood thinners, what's called antiplatelet agents, you can actually very safely and reliably open people's arteries with a very low risk of the artery closing back up. So it's been better pharmacology, better drugs, and much more active cath lab, emergency room, and I must add the paramedic system. It's all one system now. And it's also when people are in the field and your paramedic comes to your house, they do an EKG. That EKG is transmitted to the emergency room. The emergency room looks at it. They say it's a STEMI. That means there's someone having a heart attack with an artery completely blocked. They activate the cardiologist in the cath lab. By the time that ambulance gets to the emergency room, the cath lab people are on the way in. It really expedites everything being done and getting that artery opened up sooner. So it's taken a tremendous amount of resources in the community, paramedics, EMTs. They've done a great job. The emergency room physicians and the cardiologists and the hospitals themselves have to support this.
Wow, wow. You mentioned blood thinners, and there's sometimes they cause bleeding.
Absolutely.
Excessive bleeding. The substitutes are what?
Well, there's a whole different, many kinds of blood thinners. Every blood thinner has a higher risk of bleeding. The advantage is almost all the blood thinners that we use, there's some called antiplatelets, some that are broadly termed anticoagulants, all have a bleeding risk, but the risk is much less in general than the potential benefit, meaning a couple blood thinners to keep stents open and preventing a heart attack or minimizing the risk is much better than having the heart attack, but the price is you play a bleeding risk. There's a heart rhythm abnormality called atrial fibrillation, which I think most people are aware of. That takes different kind of blood thinners. 10 years ago, the only blood thinner that you could really treat it with to prevent stroke was called Coumadin or warfarin, and that's rat poison, and no one likes taking it. It's not expensive, but it has to be monitored. There's a tremendous number of drug interactions and food interactions, and you couldn't eat salad, and it was a hassle to take. In the last 5 to 7 years, there's been what's called the NOACs, new oral anticoagulants are out there. There's 3 or 4 of them which are available that don't have to be monitored, that don't have the drug and side effect reactions with food or other medicines, and which actually have a little bit lower bleeding risk than warfarin does. So these are also alternatives. Now, if someone truly has severe bleeding disorder, intestinal bleeding, bleeding in their brain, some horrible life-threatening bleeding, and they can't take these blood thinners, We typically use some of the older things out there like just aspirin. And aspirin's a very fine blood thinner unto itself, but it is not as good as the combined blood thinners or the newer drugs or even warfarin for the prevention of stroke and a rhythm like atrial fibrillation. So sometimes you have second options. Since you mentioned this, there are some newer options out there for treating or preventing blood clots in a rhythm like atrial fibrillation, because we know a lot of people cannot always take blood thinners. So there's this device out there that fits into your heart called a Watchman device. It goes into the left side of your heart. It's put in through the vein. You cross the heart, and there's a little mechanical device that some of the interventional and electrophysiologists in cardiology put into the heart to sit in the part of the heart where blood clots form in this rhythm called fibrillation. And once it's in place for 45 days, people can come off blood thinners. So it's a pretty neat little device. It has to be put in. There's a small risk. You have to make sure that it works well. But once it's in and it's working, people can come off blood thinners. So folks who have big worries about bleeding or major bleeding risk or have had a lot of bleeding in the past, actually this is something that can be considered. It's a newer agent. It's not experimental. It's been FDA approved. And it's been shown to be at least equivalent to the blood thinners with a lower bleeding risk.
Cool.
Yeah, there's a lot of cool. One of the nice things about cardiology is the technology is fantastic. There's always something new going on. They call medicine practice. I mean, things really change. And if you were practicing cardiology or even medicine now like you did 25 years ago, you'd be a terrible doctor. That's why docs really are always good about staying up to date on new technologies, because these things really make a major difference.
After a heart attack, are people allowed to exercise?
It's encouraged. In fact, there's been pretty good or very good data that with cardiac rehab, people's outcomes are better, they're much more active, their risk of new events is lower, and people are, in fact, Medicare and most insurance companies strongly encourage and pay for cardiac rehab. So what typically happens after a heart attack is you come into the hospital, unless it's a massive heart attack, people do not stay very long. They're in the hospital 3 days, maybe 4 days, maybe 2 days. They go home, they have a short period of time where we tell them not to exercise. It can be just a week. I will also add that we do a lot of heart caths from the wrist, what's called the radial artery instead of the leg now. So people don't have prolonged bed rest or restrictions from driving. And then about a week out, we usually start some cardiac rehab, a little exercise. And then once they've done that for a bit, they can usually resume to exercise on their own. I have plenty of people who are bikers, runners, racers, who have had heart attacks and other heart events who are out there doing their stuff. They have to be a little careful not to do extreme things, but for the most part, they have very little restriction, and they're really happy that they can do that. I want to get everybody back doing what they can, but exercise is really critical, and it's been shown that people who are able to exercise do much better.
Aren't people who've had a heart attack scared of exercising?
To a small degree, yes. They need reassurance. That's one of the reasons cardiac rehab is so good. Number one, it gives them reassurance. They have a little bit of supervised exercise. They have great, I work at Akron General, they have a fantastic rehab department. They take great care of the patients. People love going, and it's supervised, so it gives them reassurance that, God forbid there's a problem, there's people there. And they realize after 2-3 weeks of rehab, they're doing fine. They want to go do more, and that is the key thing. Also with risk factors, cardiac rehab, for non-smoking, for blood pressure reduction, for weight loss, it also is really additive in that regard, and diabetes control. It's really additive. They have dietitians. So for many of those reasons, that's why we like cardiac rehab. It gets people to go do exercise. I would say the vast majority of my patients who have done pretty well are really encouraged to exercise and don't really maintain any major fear about it.
Okay, we're talking post. What about pre-heart attack? How can it be prevented?
I think in general that mild to moderate exercise has been shown to be of benefit in people who are at risk for heart disease. So if you exercise, and again, this doesn't mean you don't need to run marathons. Mild to moderate exercise, brisk walking up a hill, maybe doing a little bicycling. This is not heavy-duty running. By doing that 3 to 4 times a week for about 30 minutes, it's been shown to actually prevent the development of any heart disease. It doesn't prevent everything, but it certainly decreases your risk. If you have a lot of risk factors, however, and you are worried, then that is reasonable, I think, to go ahead and get checked out. A primary physician can order a stress test just to make sure there's no marked abnormalities that were unsuspected, because that's then people who really aren't exercising much to suddenly start exercising if they have diabetes and high blood pressure and haven't done much, or they're overweight, or they smoke. it's reasonable to get some sort of a stress test evaluation or see a cardiologist just to make sure you're okay. But it is actually a tremendous benefit to begin an exercise program, sure.
Exercise and weight control.
Absolutely.
And exercise helps weight control.
It does, and unfortunately, exercise is not enough in most cases. Weight control certainly is improved by exercise, but unfortunately, exercise, even if you exercise 5 times a week, the issue with weight control is really difficult. As people get older, it's harder to lose weight. This is no great news or great news bulletin. It's difficult. And generally, if you really want to lose a fair amount of weight, more than 5 or 10 pounds, you really have to go on some sort of a diet where you have calorie reduction of various sorts. And it can be difficult. So in general, you have to, there's the American Heart Association diet for folks. There's Weight Watchers does a great job. There's the Atkins diet, which is good for diabetes. There's South Beach. There's a lot of diets out there. You can get them online. You can go to Cardiac Rehab. There's the DASH diet. It's good for hypertension. Mediterranean diet is an excellent diet for risk reduction in cardiology and a little bit of weight loss. So there's a lot of great options out there.
Lots of things out there.
There really are. There's no reason not to. But unfortunately, for weight loss, I think you have to go beyond just exercise.
This has been a fascinating and informative program for me, and I'm sure for our listeners. Many thanks for coming today, Dr.
Ardith, thank you so much for having me. It's been a real pleasure to be with you.
Forum 360 is brought to you by Electrical Impulse Communications, the John S. and James L. Knight Foundation, Hudson Community Television, the Rubber City Radio Group, an anonymous donor, the Jewish Community Board of Akron, Medical Mutual of Ohio, Blue Green, and Forum 360 supporters.